So again, thanks for the opportunity to present this work, and I would like to acknowledge Lauren North, who this is her work. She did this as part of her Bachelor of Nursing Honours degree, but she couldn't be here to present it this week, so I got the gig. And many of you will know Judy Curry, who was the other supervisor for Lauren. So we know that a lot of the work related to recognising and responding to deteriorating patients has really been situated in wards, acute medical surgical wards largely. However, we also know that mental health patients have a number of risk factors that place them at risk of clinical deterioration, including lots of comorbidities and poor mental health. And it's so good to see the new set of national standards actually incorporating mental health patients and deteriorating mental health state as part of the deteriorating patient picture. So this study was aimed at exploring clinical deterioration in inpatient mental health patients, and again clinical deterioration was defined as activation of the organisation's medical emergency team. It was a retrospective cohort study. Again, at Eastern Health we have 3 inpatient adult mental health units within our health service, 2 at one hospital and 1 at another hospital. There's 75 beds in total between the 3 units, and they admit just over 2,500 patients per year. So we looked at all patients who had a MET call in 2016 on those inpatient mental health wards, and Lauren collected the data through medical record audit. So the MET call rate was about 4.3%, so 115 MET calls out of those 2,500 admissions. Relatively young patients, few more females than males. The most common physiological comorbidities were cardiac issues and respiratory issues, and we know that a lot of mental health patients have metabolic syndromes and a whole lot of cardiac risk factors, and we also know a lot of them smoke, so they have some respiratory issues as well. About half had a history of alcohol use and about 2/3 were current smokers. The most common mental health diagnoses were schizophrenia and personality disorders. About half the patients were admitted to the mental health units via the emergency department, and about 2/3 were admitted as involuntary patients. So if we look at the most common MET triggers, about 1/3 of patients had 2 or more MET triggers, but the most common MET trigger was clinician concern, which I think is really reassuring, because I think I've been involved in teaching mental health nurses in the master's program at Deakin for the last decade, and I remember 10 years ago the focus was very much on mental state assessment and not so much on physical assessment, and that has moved like a quantum leap. And so mental health nurses are really across physical assessment now, I think more than they ever have been before, which is great. The next most common trigger by a long shot was reduced conscious state. And you can see there's a smattering of other bits and pieces there. We looked at delayed MET calls, and 2/3 of patients actually had MET triggers documented for at least 30 minutes before the MET call was made. And again, the triggers that were most commonly associated with delayed MET calls were reduced conscious state and hypotension. We tried to look at, was there a relationship between patient characteristics or diagnostic groups or medications in the 30 minutes prior to the MET call and a delayed MET call, and we couldn't find anything that was significant. The only things that were significant were that the patients who had a delayed MET call were more likely to have a diagnosis of psychosis, they were less likely to have come to hospital by ambulance, and they were less likely to have a diagnosis of personality disorder. Got no idea why that is what it is, but that's what it is. We also at our health service have a pre-MET system, so urgent clinical review, there's lots of different names for it. So we looked at how many of these patients who had a MET call were actually in pre-MET criteria in the 24 hours before that MET call happened, and it was about half. So there's certainly missed opportunities to intervene in that patient group. 60% of those patients actually got a pre-MET call, so there's still 1/3 of them that are in pre-MET criteria who are not getting an escalation of care. And the most common pre-MET criteria again was altered conscious state, followed by sort of hypotension and clinician concern. We again tried to look at some relationships between being in pre-MET criteria in that 24 hours before your MET call and some various patient characteristics. And again, the patients who fulfilled pre-Met criteria were more likely to have psychosis or bipolar disorder. They were less likely to have personality disorders, and they were less likely to have had antidepressants within that same 24-hour period. When we looked at the patient outcomes, the median hospitaling stay is 21 days. So these patients in hospital for a long time. The immediate med outcomes, most patients stayed on the ward. So 60% continued to be managed in an inpatient mental health area. About a third were transferred to a acute medical ward. 10% went to ICU, and 2% had their Met call upgraded to a cardiac arrest call. When we looked at the patient outcomes at the end of their admission, most of them went home. A handful went to subacute care or other hospitals, and there was one in-hospital death, and that was an unexpected death in a patient with schizophrenia. So again, it's a single health service study, so the generalisability of our findings might be limited. It's retrospective data, so there's a few limitations with that, and certainly the sample size was limited to 115 patients, but we couldn't create more Met patients than what we had, so that's just how it was. In conclusion, I think there is some scope for improvements in the timely recognition and response to clinical deterioration in mental health patients. Delayed activations were common. There were some missed opportunities in that pre-Met patient group. And so I think, we do have greater awareness of clinical deterioration in this particular cohort of patients, but I think there's still some scope for improvement from both a clinical level but also probably a systems level. So that's it. Any questions about